Welcome to Vital Times, the California Society of Anesthesiologists podcast. This is Ludwig Glenn. Today, I want to talk about something integral to the DNA of an academic physician, which is one of the areas that California academic anesthesiologists are powerhouses. And I want to talk about research integrity. With me are two physician scientists who have both reached the pinnacle to academic medical research. They have both held major renewable NIH grants. And I wanted to find out how they managed to navigate this area. Dr. Elizabeth Whitlock is an assistant professor at UCSF and has a program of research in long-term cognitive outcomes for older adults. She is an associate editor at both Anesthesia and Analgesia and the British Journal of Anesthesia. And she's usually found railing against isolated p-values, unadjusted confounding, and inappropriate casual language. Dr. Harriet Hopf is professor of anesthesiology and biomedical engineering at the University of Utah. She has held senior leadership roles at the medical school, university, and national levels that have positioned her for her current focus on nurturing career and leadership success in the next generation. And she's thrilled to have been selected as one of 250 images on the Utah Women 2020 mural, which is a public art installation commemorating the 100th anniversary of the 19th Amendment. So I wanted to, first of all, thank both Liz and Harriet for being here, available to participate, and to be willing to speak about their path to success and how they navigate the minefield of research. So thank you. And I will just take another moment to just sort of lay out the reasons why I want to do this. One is I want to highlight, like I said, the important research work that anesthesiologists are doing within academia. And two, I think there are a lot of pressures within academia to succeed. And I think sometimes those boundaries get crossed. Recently, there was a lot of media attention about what had happened at Stanford University, where Mark Tessier-Levine was basically ousted after people accused him of fudging some research images. I think that's a complicated and nuanced scenario. There were also issues about the amount of vigilance that was being undertaken, mentoring, safeguarding, but that's sort of why this topic came to my mind, and I wanted to get people to discuss it. So maybe I could just get the two of you to tell us more about how research has evolved for you during your careers, and we'll go from there. Harriet, let's start with you.
Sure. Let's start with the old lady. So I'm really excited to talk about this, and I think responsible conduct of research misconduct has just been a theme, not of my own personal research trajectory, but of the trajectory of science over the course of my career. And I think nowadays we kind of go, oh, this is what clinical research looks like. This is what research looks like. This is how we make research true. We have responsible conduct of research training if you're an NIH trainee. Now we've got reproducibility training, so we make sure the results are reproducible. But I started working in labs when I was in high school and college in the 1970s. And in the 1970s, we just barely had IRBs, and they were kind of rudimentary. And I worked with a lot of mentors who had never had to have an IRB and were kind of like, what is this? And why are you making me do this? And so just sort of a reminder that a lot of what we do in research is new, and that if you sort of think about the long history of clinical, I'm going to sort of focus on clinical research because that's really been more my focus, and I can't really comment on the disaster that is images and how you transfer them and how you restore them and how much possibility there is there for problems, because I don't really do research. But if we think about clinical trials, it's taken a long time to get to where we are. I would say the last 40 years has seen massively quick changes. So can I just run through kind of how clinical trials started? So the
Please
first
do.
clinical trial was in the Bible. Who knew? King Nebuchadnezzar said people should only eat and drink meat and wine. But there were some royal subjects who were like, but we like to eat vegetables. So he allowed them to eat vegetables for 10 days. And then at the end of the 10 days, he said, oh, they kind of look better nourished. So they can continue to eat vegetables. So that wasn't really a clinical trial, but it was kind of a, hey, we're going to have two groups. And then Avicenna developed some rules for testing drugs, but as far as we can tell, never used them. Paré is one of my heroes as a wound healing person. They used to treat wounds in the wars with boiling oil, and he ran out of boiling oil. And so he had to use egg yolks, oil, and turpentine on some people. And then the next day he discovered they were doing much better. And so he stopped using boiling oil. So that wasn't really a clinical trial. That's more anecdote, but it was sort of like two groups. They were Lynn did the first really controlled trial. Uh, he was a naval surgeon in the British Navy. He changed the course of empire. And in 1747, he said, we got to solve scurvy, right? They're sailing farther and farther. They are limited by scurvy. So he takes 12 sailors. Imagine this 12 sailors changes the course of history who had scurvy. And he said, we got 6 dietary supplements we can use, and 2 sailors each are going to have each of them. And it turns out 2 of them who got lemons and oranges every day got better so fast that within a week, one was back in active service and the other was running the sick bay. So that was a huge clinical trial, but no blinding, no randomization, nothing to reduce bias, but it was a big answer, right? And I think that's one of the things. The early clinical trials were answering questions where there's, if you think about antisepsis and penicillin, sorry, they're all wound healing related, but these are things where, if you don't have vitamin C, you don't heal. If you do have vitamin C, you do heal. You don't need more than 12 sailors to prove that, right? Like it's just done. It, so in the 1860s, now we have the advance of using placebo for drug trials, which is a really big advance, right? Before that, they weren't doing that. The first double-blinded controlled trial was in the UK in 1943. It was using something called patulin for the common cold. Why do we not know what that is? It did not work. So yet. But then in 1946, they did the first randomized controlled trial, and that was for streptomycin for treating TB. And it turned out there were shortages of streptomycin, so it was ethical to randomize because this is around the time of the Nuremberg trial, so they were thinking about ethics. And they had a statistician who said, let's randomize it, and he figured out a way to randomize. And that was the first time it wasn't just alternating or some convenient sample. Then we get ethics starting to come in 1947 with the Nuremberg Code and Helsinki human subjects within 1964. And in the 1970s, we find out what happened in Tuskegee with the syphilis non-treatment. And that really is what triggered at the beginning of my career, hey, maybe ethics is important. And I will say, you might argue, well, is ethics really research misconduct or is it just, human misconduct? But I would say if you're not behaving ethically, your results are much more suspect. And we did not get useful information out of Tuskegee, right? We already knew how to treat syphilis. We didn't really know how not to treat syphilis. And so now the NIH has started funding research in the 1940s. Hey, who got the first NIH grant? The University of Utah. Just have to throw that in there. But now the NIH is like paying people to do research, and they start to realize that fraud, all kinds of misbehavior, research misconduct is a problem. And then they start requiring this responsible conduct of research. And finally, in 1996, we get good clinical practice, right? Those are the universal clinical standards for clinical trials. We got the consort, strobe, we got all these things you got to follow. When I think about me starting out in the 80s doing clinical research, there was a whole lot of like, well, it feels like it should be significant. So, but if I drop that person who's an outlier, then it is significant. So I'm going to do that. And that wasn't research misconduct at the time. That's just kind of how people did statistics. And then statisticians, the great heroes of clinical research, came in and said, that might be a problem. And that's when we got to the idea of intention to treat rather than exclude. If people die in your drug study, we're not going to count them because we lost them to follow-up. But what if the drug actually killed them? That would be good to know. That might actually impact it. So I think when I think about research misconduct, and I think about like, how has research misconduct evolved over the years? I think we didn't know how to do research well. So there was a lot of stuff that was just not good practice, but not fraud or purposeful. And so I think one of the things that's really fun, we have a classic article journal club. And when you read these articles that are 20, 30, 50 years old, people's eyes are wide as saucers. They're like, "They did what? They studied 3 dogs?" It's kind of intriguing. So I think one of the things that's happened is we've gone to the point of, like, big differences, who cares what your statistics method are? It's obvious it passes the eye test. But now we're getting to small differences. Liz is trying to make small differences in people's outcomes. I'm trying to make small differences in people's outcome, and their bias and confounders really get in the way. And there you start to have more temptation to kind of go, how do I get rid of this bias and confounders? I'm going to just include some more bias so that the results come out the way I want them to. And then research has gotten harder and harder and harder, right? The easy stuff we've answered. Now we're trying to get into the complex things. It's got to be multidisciplinary. That makes it much harder to have oversight, right? Like a lot of these issues, like Marquez, like he's got the big lab. There are lots of people working on a lot of things. There are people doing stuff that that the research PI doesn't understand how they do it, right? You sort of try to understand what they're doing, but there's techniques that you don't own. So it's much harder to have good oversight. And then there's some, I think, incompetence, lack of understanding, there's lack of effort to understand, and then there's shortcuts, and then there are incentives. And when I think about incentives, I think about
Mm,
there's lots of different kinds of incentive. I want positive results because it'll make me feel good. It'll allow me to get promoted. It'll allow me to get published. People will say, "Hey, you're great." I will say it's interesting that negative results are actually the most interesting things we get. If only we could deal with failure and kind of figure out what they mean. And there's also another big incentive, and that's funding. And here's a really interesting thing. We've had lots and lots of retractions, tons of retractions in anesthesiology. We own some of the top places in numbers retracted, like 194 papers, 172 papers, and none of those that I know of are pharmaceutical research. There have been shenanigans with pharmaceutical research, like claiming stuff that you really can't claim, blocking research from being published that's being done. That happened with Synthroid and the generic version. But generally, pharma studies, the FDA has had high control for a long time and they're done well. The NIH has funded lots of fraud. That's why they're so concerned about it. And so that's, I think, one of the things that I think is a really important thing to say is there's a tendency to say, oh, they got industry ties, so their research is suspect. But if it's funded by the NIH, must be true. But the reality is, just as in industry, I'll make more money if my drug gets approved, and so I might be biased and allow things to happen that aren't right. If I don't get good results on my NIH grant, how do I get my next one funded? And so that is a big driver of it. And then the last thing I will say is a big driver is research is really hard work, and it's frustrating, and you fail, and I think some people are just like, "I'm tired of that stuff. I could just make stuff up that aligns with what people believe. It'll get published, and I'll be famous, and I don't have to do anything about it, and no one's really watching me." So, there's
also true.
whiplash.
Also true. I think, the incentives are a really interesting concept. Liz, I wanted to get your thoughts about this. You're
Yeah.
not to insult Harriet, but you are of more recent vintage, and you've
I got
succeeded.
right.
You've succeeded, and I would love to hear your perspective about this.
Yeah. Well, I've been fortunate to be in a few different scientific research settings and seen a bunch of different mentorship. And I think we alluded to the power of mentorship in helping define good practices and healthy attitudes around research and research failure and success. And so I've been lucky to learn from some mentors that I think have handled this well. I cut my teeth in clinical research with a mentor who is really great at negative trials. Not that he wants to be great at negative trials. We would all love to show that something is benefiting humanity. But you have to learn, I think, early in your career what to do if your hypothesis is wrong. Some of the challenges that we see in the medical literature in terms of accuracy come from being really in love with your hypothesis and being really uncomfortable with the idea of that hypothesis being wrong. And it's just like really human stuff. And this is totally separate from deliberate misconduct. This is scientists trying to do the right thing, and produce evidence that helps, again, move the field forward. But being open to fail and knowing what you're going to do if your hypothesis is incorrect, making sure that the journals understand that research describing negative trials, quote unquote, is just as important as a positive study. A p less than 0.05. Gosh darn it, I can't tell you how many times I've struggled to get a paper published because the p value was greater than 0.05 and somebody interpreted that as, we now know nothing more, therefore this is not of interest. And that kind of attitude, and that's why I asked Ludwig to mention my editorial board roles. A lot of this comes in the peer review process too, helping the gatekeepers of published medical research understand what makes science strong, and it's not necessarily a p-value. It's seldom a p-value. It comes down to the design and the conduct of the study.
I wanted to ask you a follow-up about this.
Yeah.
So early on, when you may have, I don't know, I haven't looked it up, but when you may have had a negative study result, how were you advised to use that in a academically constructive way? Because I think that our audience would like to hear that.
Yeah. So I hope that people find negative studies that are well conducted just as interesting as positive studies. And sometimes you got to make your brain bend and do that. If you are designing a study, you should design it in such a way that the answer is interesting and relevant to human health, whether it is positive or negative, whatever your effect size is. And so where, for me that comes out is I pre-specify my hypotheses in the analysis. I write down an analytic plan that I try not to deviate from. But even at the beginning, before I've even touched the numbers that I'm going to be analyzing, I have to know how I would view, you know, effect size that says this factor is protective, and one that says that it is harmful, and one that says that it doesn't matter. How am I going to put that into a story? And then as a researcher, I feel also really obligated to make sure that I move forward with publication, even if my study is negative for a certain factor. Now, again, it can be harder to get those published. It can be harder to find a home for papers like that because people don't find them as compelling often. But if you've done the work and the study itself is strong, then you should probably make sure that gets into the world so other people can benefit from it.
And this is Harriet. Can I add a little bit to that? Because that's, I think that's such an important point and such an important thing. And so I am a little jealous, Liz, that you had such great mentorship around how to fail. I think that's a fabulous thing. And I know you are passing it on. I will also say, I'm going to reiterate something I said earlier, which is I think when you don't get the result you expect, that's the most interesting result. So if you think about science, we create models like this is how the world works. And if you get a result that doesn't fit the model, that it's really intense, that feeling of, I got to find some way to make it fit the model. I've got to find some, right? So if you think about the structure of the atom, right? Like all of these great big theories that we have now, structure of the atom and people thinking that the electrons were in a knowable place and then realizing that they really weren't. And there were some amazing studies that showed they weren't, right? That was people going, okay, this is an unexpected result. We're going to follow up on it. But if you have an unexpected result, it means your model is a little bit wrong. Not necessarily an earth-shattering relativity upset, but something about your model is wrong. And therefore, it's important to go back and say, okay, what's wrong with the model? What study can I do to find out what's wrong with the model? I think sometimes we're doing studies where it's sort of like, well, I hope this thing works. Let's see if this thing works. But oftentimes we're doing that study to see if something works because of the previous literature that suggests that this next thing should work. So I think I'm going to say it's very frustrating to get negative results, but if you can get over that and look at them and think about the context that the negative result came in, it might be you didn't design the study right, right? Like that's one possibility, but it might also be that we need to have a different understanding of whatever that process is that you're studying.
Thank you. I was thinking as both of you were talking about these negative studies, and I'm thinking about it as a consumer of these studies.
Mhm.
recently I was looking at some regional anesthesia output, and I'm an intensivist, but I love regional anesthesia, and there were a couple of negative results, and I have to say I was kind of devastated. I thought, oh, I can't
Literally,
sort of.
I,
are you talking about the hip fracture
yeah,
studies?
because I
Hip
was
fracture
just thinking
anesthesia
that's
Yes,
such
studies?
a perfect
yes,
example of this.
yes, yeah.
So
And I
let me,
thought, oh, I
this,
can't
Harriet,
be
I
this
think
smug regional anesthesiologist.
this is but look at that study, right? It contravened people's expectation, and it's always
Right.
much. It's there's this bias. I can't remember the word now, but Liz will fill me in on it. If something matches what you think is going to happen, then you're really excited to put it into practice. If it
Confirmation bias.
Thank you, confirmation bias. If it doesn't confirm your bias, then you're like looking for reasons it's not true. And if you look at on social media the reaction to that study, right? Like it was a well done study. It's not the final say on are there people for whom original is good? Would I still get original? Yes. But maybe it's up to the patient's choice now, right? Like, so I think, but there was just an outpouring of anger at the study, right? And I think you can always do better with studies. And also I think confirmation bias, and I don't know, Liz, I will let you talk about this, and then I will give an example of confirmation bias and the trouble it causes.
I was wondering if Ludwig, do you think it'd be helpful to give like a 1-minute overview of the hip fracture anesthesia trials that
Oh,
came
that's a good
out,
idea.
just to make sure that people know what we're like gasping about here?
Yeah, I am not prepared to do that. So if you're ready
I
to do
am.
that, Liz,
Of
you
course
go
Liz
ahead.
is.
Yes, this is awesome.
I
This is
was
even better than I thought.
at the ASA annual meeting in October, like 2021, I think. That Mark
2,
Newman, who was the 2020, but yeah, Mark
last year,
Newman,
a year ago.
primary author of this New England Journal paper, the Regain trial, huge multi-center randomized trial in the US and Canada, randomized older patients with hip fractures to get general anesthesia or regional spinal anesthesia, with a primary outcome of being alive and able to walk at 60 days. And so he gets up and he presents that the data are exactly the same for the two groups, that it is no different. And now this was spinal according to like typical practice, which means that older patients were getting sedation during their hip fracture. But I gasped. I was shocked. I'm pretty sure the rest of the audience was. I was astonished because this is a beautifully designed, very transparent, massive trial. But there's always that like, oh, gee, is this maybe not true? Like maybe this was just unlucky that there was no difference. 1 month later, a trial out of China came out, another really large randomized trial, hip fracture, older patients, where the spinal group got no centrally acting medications, whatever, like no sedation, no midazolam, no nothing. You got your spinal and you lay there. And same thing, primary outcome of delirium, no difference. And it just completely changed the paradigm for me of what general anesthesia does to older adults' brains, does to their long-term outcomes. And it was met with a decent amount of backlash, despite having two totally separate trials confirm roughly the same thing. There was quite a kerfuffle on the internet, and people didn't want to believe it. And sometimes, the loud people didn't want to believe it.
Well, I think, I one of my favorite concepts in medicine is hubris, to not have hubris. But I think hubris could be positive or negative. And I think we very much desperately want to feel like we know what the best paradigm is for a particular patient type. So I think that was very mind shattering to feel like, we can't do as much as we thought we could. So yes, that's the context was all not okay, but we have to abide with that. That's science, right?
Yeah.
Yeah, and yet, Livy, this is Harriet. The one thing I want to say is I think very few people have changed their practice as a result of this trial, or very few of the people who had very strong bias at the start have changed their practice, right? Like, so this is the kind of negative trial that makes that's it's hard to change an opinion, a belief, a way of practicing with a negative trial because people, the thing about confirmation bias is I can go into any clinical trial and say, here's all the 57,000 things that are wrong with it because you can't do a perfect trial, right? And especially when you can maybe in related mice, but in humans, there are just so many confounding factors that we can't account for. So that's a problem. But I want to give the flip side of that, which is the incorrect but aligned with confirmation bias study that changes practice overnight and turns out to cause harm. And just to get back to our sort of research misconduct theory here, this is not a story about research misconduct. It's a story about a very well-intentioned trial that was done to the best of their ability in the, I want to say, late 80s. So we weren't as good at what we did. We were missing some knowledge that we have now. And that is the very famous VA beta blocker trial in non-cardiac patients or in patients undergoing non-cardiac surgery who had high risk for cardiac outcomes. And the fundamentals of the trial are they randomized patients to get beta blockers before, through, and after surgery or not. And they found much better outcomes even at a year for the patients who got beta blockers. And as a result, and that aligned with people's beliefs at the time, it must have been in the 90s actually, because just thinking back, and it aligned with people's belief at the time that slowing people's heart rate down was good and we should give beta blockers. And so pre-op clinics around the country, certainly at the site where the study was done, started giving like everyone over 65 beta blockers, everybody over 65 beta blockers. And then there was this thing called the POISE trial. And the POISE trial showed that, yep, giving beta blockers to everybody reduced cardiac events, but it increased stroke in a completely offsetting way. So there was no benefit. And then we stopped doing that. But what I want to do a little bit is go back and talk about the trial. So the trial was done at the VA. 100% of the participants were men. Lots of women got beta blockers, right? So, because we just believed it was generalizable to everybody. Some patients came in on beta blockers and were randomized to the no beta blocker group, and they had their beta blockers stopped. So really what the trial shows was, do not abruptly stop beta blockers. It's harmful, because that was really the problem. And so I think that's sort of an example of harm caused by research that was state of the art at the time, we'll say, but had some major flaws in how it worked and led to harm being caused to people. But then here's the good news. There were other people who were curious and who did a trial that showed what the problem was at that trial. And so we stopped doing the harmful behavior. And so Liz, what are your thoughts on the famous VA beta blocker trial?
Well, so not specifically on that trial, but I think what we've talked about a couple of times is evidence reversal, and how we can believe one thing for a while and we can even believe it like a lot, and then suddenly when that thing changes, you have to put that into your mental model of the world somehow. And you can feel about it two ways, right? One way is, well, that can't possibly be right. I've only been doing it the right way all the time. And I worry that, sometimes people get stuck in that mold. Then there's of course, oh, we've learned more, we can now do better, we can do differently because we know more. And we're trained as scientists. We've all gone through medical school. Like, you are trained to ask questions and follow evidence in school. And I think one of the things that has been so hard about research misconduct is that people who maybe don't have this background are not comfortable with evidence reversals. It's like, how do those doctors think spinal was so right and now they're saying I can have a general? Like, that can't be it. Don't pry my beta blockers from my cold hands preoperatively, right?
Well, don't, because now we know that you should not.
Yes, we're writing on them, do stay on a beta blocker. That remains true.
Yeah.
But I'm curious about how you guys feel that the public perceives evidence reversals, which are like common and sort of normal in science as we learn more, but don't always come across quite right for people who are maybe a little bit less in the science.
Liz,
Wow.
I think that is such a great question, because I think I like to kind of inhabit my scientific world. I think this, the hip fracture study, that was all out on social media so everybody could see us fighting over it, right? And I think But I think one of the challenges we have is how we communicate to the public, right? We are very good at communicating with each other. We are much less good at communicating with the public what all this stuff means. And then tempers run high because people have confirmation bias and strong beliefs, and so they kind of accelerate the argument so that it's not about conclusion reversal, evidence reversal. It's about you must be wrong and you're a bad person and right. And that I think is a big problem for sort of public perception. But so so I don't know that I have a solution to science in the public, except I think we need to make scientists better at telling stories about their science and maybe better at telling stories about things like evidence reversal and research misconduct and all of those things. Uh, so I think it's a hard one, but I think scientists also have to get better at this, right? Because we're human, and it is painful to have a way you've been like it's kind of a are you saying I've been harming my patients? Are you saying I haven't been doing the right thing for my patients? Like physicians take pride in doing the right thing. And I think one of the hard parts about evidence reversal is, wait, but I was doing the right thing and now you're telling me it was the wrong thing. And so there's, I think, a lot of shame and guilt associated with I was doing the right thing, even though it was the right thing at the time. My personal passion is how do we teach the next generation to read the literature critically? And Liz, you talked about how we learned it in med school. I'm going to argue we didn't really learn it in med school. Like we got
I think we're
statistics.
learning it more now than
I
we
think they're doing a much
were.
better job than I mean, but when I got statistics where we actually by hand calculated t-tests, which I didn't know when you would use a t-test, but I knew how to calculate one, right? And I also say that we use t-tests for a lot of things you shouldn't have back then because we didn't know that no one had we didn't have this brilliant statisticians coming up and going, "Hey, wait, there's a problem with that." So I think like we have a quality improvement rotation, and when the residents on there are on that rotation, I do a one-on-one journal club with each of the residents coming through. We spend an hour. They pick out an article. There's some guidance on what kind of an article it is. Then they present it to me, and then we just talk about sort of how do you understand the statistics. And one of the most sobering things I read, this was a British medical journal article a few years back. Hopefully, it's a little better now. And Liz, this gets to you and the importance of editorial boards and the importance of the peer review process, and really the importance of reviewer number two who is standing firm on p values, right? But British Medical Journal, they did a study where they showed that in abstracts of journal articles, the conclusions were systematically overstated. That was worse in the titles. And if there was a press release, it was even worse.
Yeah.
So if people are just reading the conclusions, they are taking something from the study that isn't proven by the study. So one of my things is people need to read the whole study, at least the whole abstract, at least kind of get a flavor of, do I believe this? So that's really what I work on there. And then as a reviewer, I'm like, I'm going to hold authors accountable to the title, not overstating the conclusion and to the conclusion, because that's what people read. And so I think getting people to read more, getting people to feel confident that when they read it, they have an ability to dissect the results. And then once you've dissected the results, being able to put it all back together and say, okay, here's how I understand the study. Here's the problems with the study. Here's all the ways I can rip it to shreds. And here's my conclusion of how am I going to incorporate this into, my practice. Usually won't make a big shift, but just sort of like, well, maybe if patients want general, I won't try and talk them out of it. Right. Like that's where you can go to.
Mhm. Well,
Okay. Oh, sorry, Liz. Go ahead.
there's this thing that hasn't really caught on, but it's called an independent discussion, where you, the scientist, produces your methods and your results, and then the discussion is written by somebody not involved with the study, simply on the basis of what was done and what was shown. That the interpretation is left up to somebody who doesn't have a horse in this race. Not that it hasn't happened very often. I participated in one a few years ago, and that's, kind of a cool way to try and force you to understand what it is that the results actually are saying and how to put that into words, rather than perhaps an author is inclined to overinterpret, because we all love our hypotheses. We love them so much.
We worked so hard on them.
Yes.
That's kind of like the New York Times articles that I love to read in like the it's not archaeology, but like I'll read stories about some new dinosaur they discovered, and they'll, interview the authors of that paper. But then they'll go to some other dinosaur experts at some other university, and they'll look at the evidence and go, well, maybe, but maybe not. So that's kind of what you're saying. It's somebody who's an expert, but is not part of that study team, and hopefully is a little bit less even unconsciously biased about this. I
Yeah.
wanted to follow up with the two of you about different types of research errors. And I know that both of you work primarily within clinical research. So we haven't talked about this much, for example, cell biology research, molecular biology. But I wanted to ask, are there certain types of errors that happen more often or that are more prone to occur during the development of a particular study design? And what are the ways that you can brainstorm about trying to minimize that occurrence?
So,
Yeah.
go ahead, Liz.
You mind, Harriet?
No.
So I do observational data research, and I don't know, 10 or 12 years ago, there was this article that was called, I think, Armchair Research and the Power of the Retrospectoscope. And it was really quite cutting
Like,
about how, you could sit here and do your computer and come up with all sorts of conclusions and publish 1,000 papers and become very famous doing very, very little actual work. And it wasn't totally fair to observational researchers, but the grain of truth in there is that if you are an observational researcher, you recognize how much freedom you have to tailor your findings to your own imagination, your own beliefs of the world. And that's in observational research, we are moving much more towards good documentation, like essentially a lab notebook of what you've done, solidifying your analytic plan up front rather than kind of getting down the line to the analysis and it doesn't show what you think you were going to see. And then you sort of massage a little or make some changes. And these can all happen very unconsciously. But I write an analytic plan and keep referencing back to it so that I keep myself intellectually honest about what I was planning to research, what finding I was planning to meant to elicit, and that may not always be the thing that's easiest to publish out of your analysis or out of your data, and yet it was your primary outcome. You should have put your chips down to say that you're doing this. Journals are increasingly asking for these pre-specified analytic plans just to make sure that people haven't been using the freedom of data dredging to come up with stuff that looks publishable. And so that's kind of like it's a kind it's like an ethical, I don't even know how to say this. It's not me. Like I don't think there are a lot of people really digging in data so that they can publish stuff that's not true. It's just human. But it is possible to do stuff that's genuinely misconduct. It's possible to massage the data in a way that you're doing wrong and you're just trying to get the publication. And then there's something kind of in the middle where it's like, I just didn't know what I was doing well enough and I messed up, but I didn't catch it because I don't recognize that I was doing it wrong. I worry about that one too. Coding errors can happen. So we, in my group, we cross-check each other's code. We do code reading, which is very boring, but very important to make sure that, you haven't gone through and accidentally mistyped some variable name and come up with a false finding. It's possible to do it. But it all kind of centers around the quality of the research and forcing yourself to put out research that's of high quality and to adhere to high quality research methods that should produce something, again, that is publishable, that's disseminatable, that's true. And then it goes through the helpful filter of expert reviewers, hopefully, who say, well, I don't believe this. I think you should do this. What about this bias and this confounder? And how do you answer these questions? So running that gauntlet through publication is also very critical.
Let me ask you this. So you're
Elizabeth, can
talking
I
about
just
intellectual rigor. Oh, yes.
can I just
will.
add a little bit of that? Because I think,
Yes.
for example, so first I wanna set the bar that we have identified a lot of fraud. It's largely men, interestingly enough, a lot of times in big labs that are highly productive, because I think that's a a place where it's harder to have oversight, it's easier for something to slip through, whatever. But we do not actually know how much fraud is going on. It's possible most fraud is committed by women. We're just better at hiding it, right? Right? Like so I think the thing about research misconduct, I think Liz did a very nice job of sort of saying, like, there's people who are purposefully not just making up data, right? And then there's people who are just following every rule. And then there's sort of a bunch of people in the middle who aren't sure what they're doing wrong. And I would say even the people following every rule at some point are actually doing something wrong. And I think that's sort of the important thing is the fact that this is a growing area and you've just got to do your best to do it the best you can, and then in 10 years, you'll go, "Well, that wasn't actually the best we can, but it was the best we could do it at the time." So, and then research is just hard, right? And people don't have a lot of time, and what Liz is describing takes a long time. You can do kind of a small little observational trial without following all those rules, you can probably get it published a lot faster than Liz can. And I think that's one of the counterproductive pressures that we kind of count publication, right? Like if I think about things that drive fraud, we're counting publications. It's much easier to publish something that isn't very good. And I'm going to finally say, I'm so glad you're on an editorial boards, Liz. I have been on editorial boards. I have stopped doing that in my current life, although I still review a lot of papers. And for the people out there who've been asked to review and have said no because they don't have time, this is one of the most important things you can do. And the more reviewers we have, the more likely we are to have a reviewer who understands the science well
Yeah.
enough to give a good review.
Yeah.
What I wanted to ask both of you is, in that vein, when Liz was talking about the steps that she's instituted in her studies to try to really guarantee a quality study result, Liz, I feel like you're talking about intellectual rigor and responsibility. And that responsibility and that rigor need to come from both the authors, but also the reviewers.
Mhm.
And my follow-up question to both of you is, there are a lot of people who really want to publish. It's right now residency interview season. There are a lot of medical students who are really ready to have some publications on their CV. Just to cite one example, I'm not saying that those are the only enthusiastic submitters out there, but there are a lot of people who want to publish. There are a lot of online publications that want submissions. So how do we control for that, and how do we know who's actually doing a rigorous job?
Yeah. I I'm really nervous about the proliferation of online only journals. I I get maybe 3 or 4 solicitations per day in my inbox saying, "We're gonna waive the publication fees for you specifically. We're missing just one article for this." Like they're clearly predatory journals. I would expect that they would have cursory or no review process whatsoever. But once, if it were a Medline index, if it goes on PubMed, it can be really difficult to understand the journal quality and the quality of review that's expected. I don't want to be a snob, but the truth is that certain journals are much more rigorous in evaluating the manuscripts that are submitted than others. Some journals barely evaluate the quality of the manuscript, barely make an effort to send it out to people who know what they're doing. And it requires a tremendous amount of effort to articles. I probably review 30 or more unique manuscripts per year. And this is uncompensated work. And it takes me hours to do a manuscript thoughtfully, but I am really aware that, particularly with clinical research, if I let something through that's not true, it can be picked up by a news outlet and it can absolutely sensationalize a field and be retweeted and be, covered. And it's not true. And maybe as a reviewer, like I may be the last stop for something like that. So the whole mechanism has to work together and be trustworthy for this to for scientific output to be itself trustworthy.
So this is Harriet, and I want to say predatory journals are a scourge on this earth, and it's a tragedy, and we are caught between pay to publish and pay to read. Pay to read tends to have more oversight, but then a lot of people can't access it. That's our traditional journals. I would also say if you look at Retraction Watch's top 10 retractions, top 10 retracted authors, Joachim Bolt published in the big journals.
Yeah.
Scott Rubin published in the big journals. Fuji published in the big journal, right? And that is the problem, is that you have to figure out how to catch the fraud. It's that fraud. People have gotten very good at fraud. I will also say I admire the anesthesia journals because we do own, I think, 2 of the 3 top spots still. And it's interesting to me that Scott Rubin of multimodal analgesia fame has kind of dropped off the top list because he was, it was in the 90s. People didn't publish as much then. Now you got people with 194 retractions, but the journals figured them out. And I think the anesthesia journals have done a great job of thinking about, like, what are the requirements for authors? There's reporting guidelines for almost every kind of study type, and most journals are holding them accountable. Journals have hired statisticians because it turns out statisticians can often pick up fraud because the data aren't really random the way that people create them in fraud. So I think our journals have done an amazing job, and I trust the results much more now than I used to. But I will also say it can be really hard to identify that someone made up data. And so I think review is really, really important. But I would also say that you can't say, oh, it's an open access journal. And I will say there are open access journals that are not predatory and that are predatory, but you can't say, oh, it's open access, it's not quite the same review. And so all of the fraud is going to those journals. No, because the people committing research misconduct on purpose, let's say, they want to get promoted. So they're publishing in the big journals and they are creating erroneous data in order to get published in the big journals. The stuff that gets published in open access predatory journals is probably less accurate, but less purposeful, right? So that's kind of how I look at it. And then I will also raise COVID-19. Huge outpouring of articles that were inadequately reviewed because people were stressed and wanted to get answers. Huge numbers retracted. And yes, that reevaluation of evidence has caused huge public health problems, right? Oh, hydroxychloroquine. Oh, right. So, yeah. We can't hear you.
Oh, Ludwig, you've become muted.
Oh, I muted myself.
There you are.
It's like going way too well. So what I was saying was this conversation has been amazing, and there's so many different things that I really wanted to ask. But I do want to actually, for the sake of our audience, wrap this episode up. So I'm going to ask you one last question, which is, we've talked a lot about the history of research and how things have evolved over time. What do you two feel like are some of the valuable safeguards that are now in place to shepherd better research integrity?
So I think the first is that I think science is a learning organism and we learn from our mistakes. When I work in the operating room, I always think of the anesthesia machine as a memorial to all the patients that we killed before we realized things like, oh, oxygen has to be the last thing to go in. Oh, maybe the vaporizer should be, and the gas tanks should have keyed fillers, keyed things so you can't use the wrong one. I think that is true in science as well. A lot of the stuff that's been reevaluated, a lot of the lack of reproducibility has been because we didn't understand how to do science. But doing science wrong is how you learn how to do science right? Like you can't just kind of sit down and go, I'm going to just off the top of my head. You got to start in the Bible and work your way up and kind of do ever better trials as the questions get harder. So I think one thing is I just have confidence that we are always going to be learning. I think rethinking our promotion, rethinking our recruitment, rethinking all of those things so that there isn't pressure to have numbers, but rather there's pressure for quality and that we give people the time that it takes to achieve the quality. I think we haven't really adapted. We've adapted our science to the times, to the changes, to the evolution, but we haven't adapted how we think scientists should work their way through the promotion process in the same way because it just takes much more time to get a paper done. So I think those are things. Good mentors are hugely important. And I think if we get back to our starting point, Mark Tessier-Levine probably was a very sought after mentor because he was famous, but he wasn't necessarily a good mentor and he wasn't producing oversight. And I think these giant labs are a place where it's difficult to have oversight. So how do we kind of figure out a way to have the giant labs that we kind of need to get the work done, but also make sure you got oversight? And then I think we've got lots and lots of people creating rules and trying to teach the rules. And so I know people hate it when you kind of put barriers to moving forward in your research, but IRBs, they have an opportunity to hold people accountable to doing the research right. Reviewers for journals have that possibility. Reviewers for the NIH, that's another thing. What gets funded by the NIH? Are the reviews right? And then I would love to see some science on review. Like there's some science on review, but science on how do we do reviews so we get the best science through, not the science that goes with confirmation bias or goes to the lab that people know or, whatever all the biases are in there. So I think there's lots of ways we can improve science. And I would say over the last 40 years, I've seen huge strides in making research true.
For me, I think the two main things that I think are becoming more apparent are transparency and teamwork. So if you have a pre-specified analytic plan that you can send to a journal reviewer and they can see that it's date stamped and you have adhered to that plan, it's not so much the reason the Regain trial got published in the New England Journal was not because it had this shocking finding in favor of something. It's because the research was rigorous and transparent. There was a multi-hundred page probably document detailing all the procedures and everything was pre-specified. And the truth is, when you see a study like that, you basically believe the conclusions because it is so transparently reported. You know exactly what was studied and how. And observational research is and should be no different, that I should be comfortable showing you my code. I should be comfortable showing you all the sensitivity analyses. In fact, I find it very difficult to write a method section because I have to, or a result section, because I have to limit how much I'm talking in there. But that's why we get the 30-page supplement with all of the secondary analyses that I did to make sure my conclusions are robust. The sunshine in research helps people believe that it's true. And for good reason, because there's nothing that I as a researcher should have to hide. Similarly, when I'm working with a big team, we all mutually are very aware of what everybody individually is doing and what their responsibilities are. And we cross-check each other's work because I'm not just me and a computer able to make solo mistakes, able to transpose some variable values or eliminate a few people from my data set without anyone knowing. So those kinds of interventions both make research more fun because you can see what happened and you can really feel like you've got a great grasp of the content and in a study. That's the transparency piece. And then it's fun for a scientist to be working with a bunch of people, everybody mutually supporting each other in behaving with integrity, in, maybe one of us is really good at processing failure. I can sometimes be that person for my team. No, we don't have to be sad about this finding. This is how we can maybe interpret it in a way that makes it useful, not somehow a barrier to, getting the CV stamp of some paper somewhere. So I think for me, where I see so much evolution is in the transparency that's now required for high impact clinical research studies and in growing teams that work together over a long term.
I love that. I was just thinking when the two of you were talking about this, that without needing to, we have totally confirmed what is really exciting and inspiring about medical education, which is when we do learn over time, the iterations actually do help, and transparency matters, teamwork matters, and we talk a lot nowadays about the importance of mentoring. So the two of you have, said that as well. So in a way, this totally confirms that the need for all of us to be invested and engaged in this process. And it's true. I think we can learn and educate ourselves and the future generations about better research practices. So, I think those are all very, very good points to take away from this conversation. So, again, thank you both for taking the time to share all of those experiences. And I think it's a lot of food for thought. And I think, you know, academic medical professionals are a very rarefied breed, but we're, we, and I'm going to put myself in that, we are all very type A aspirational competitive people. And there are things that happen to people like those in certain situations. So, yeah, I think this has been a really good discussion about all of that. Before we wrap up, I wanted to ask both of you if there are things that you want to make sure that our audience takes away from this conversation.
Yeah. For me, it's that everybody can be an active and engaged consumer of medical literature. Whatever that means for you, however deeply you'd like to get into it, the point is not to just passively receive the material. It is to apply your own knowledge, to increase that knowledge, and to ask a lot of the scientific enterprise because it is so critical to what we do.
And I guess what I would say is first, I think there's a big intimidation factor. And so I think my message is we need to figure out ways to teach reading the medical literature in ways that aren't intimidating. And then the second thing is I think we have a lot of perverse incentives in research and in medicine. And we need to start thinking about how do we support people's research so that it can be aimed at the long term, so that it can be done the right way with transparency, so that it's not about, salami science and getting a whole bunch of stuff published, so that it's about the things that people feel passionate about, and so that you can get promoted for doing really strong science that doesn't result in 700 papers or in positive results.
Beautiful. Well, like I said before, I could go on for like another hour about this, but for the sake of our audience, we will bring this episode to conclusion. So this has been another incredibly inspiring conversation for me for the Bible Times podcast for the California Society of Anesthesiologists. I would like to thank Dr. Elizabeth Whitlock and Dr. Harriet Hopf for participating. And if you liked this episode, make sure that you subscribe and keep on listening. Thank you all so much for joining us.